Alright, let's get into endocrine emergencies. Don't think we'll get done with it. It's not a very, very long presentation. There's a few particular endocrine disorders that we're primarily concerned with. Can you think off the top of your head what they are? Diabetic issues. Hypoglycemia, hyperglycemia. We'll get into some of the pancreatitis, abdominal pain, things like that. And then thyroid. We're going to talk about, we're going to get a little bit deeper than when we were in advanced DMT about Thyroid Storm and Thyrotoxicosis, that word. So if the neurosystem is your electrical messenger, the endocrine system is your chemical messenger, right? And the endocrine system works on the body through different mechanisms. One of the primary mechanisms is negative feedback, and we're going to talk about that. And it also works on target tissues in the manner in which they secrete the hormones or the chemicals. The endocrine system, it consists of glands and hormones, all right? Some hormones are, or some glands release their hormones through ducts, and then some release their hormones directly into the tissues. The purpose of the endocrine system, just like the purpose of any other system in the body, is to maintain homeostasis. The endocrine system has just been tasked with a much larger job of maintaining homeostasis because it pretty much monitors every aspect of the body, along with the neurosystem. It can also promote permanent structural change in the body. To maintain homeostasis, there must be responses to changes in the body, and that's going to work off the negative feedback. Example, low glucose or low calcium levels, then the endocrine system is going to release certain hormones to increase glucose or to help intake calcium. You've got your exocrine glands, which secrete the chemicals through ducts. And then your endocrine, they secrete chemicals inside the body into the tissues and the blood. With the exocrine, these chemicals are secreted for elimination. These ducts carry the carry the secretions to the surface of the skin or directly into a body cavity. Your examples would be like your sweat glands or your salivary glands, and also your liver. With your endocrine, they release hormones directly into the surrounding tissue and blood, which increase or decrease the rate of cellular metabolism, which is going to be one of the primary ways that the endocrine system maintains homeostasis. They also transfer information between the cells to coordinate body functions. Examples like regulation of mood, metabolism, sexual development, and also sexual function. Your hormones of the endocrine system are going to be released, or let me rephrase that, particular hormones of the endocrine system are going to be released from particular glands. Unlike the neuro aspect of chemical, or unlike the neuro aspect of messaging through the body where it sends a direct impulse and it acts immediately, these hormones, they are going to act more slowly, the nerve impulses. Their whole goal is to be released and travel through the bloodstream to target tissues. And then these hormones, or let me rephrase that, the cells have receptor sites, target sites that these target hormones are going to act on. That's the only way that they can act is in the receptor themselves. All right. just like with your medications, you've got your agonist and your antagonist. A lot of your medications that you would take for endocrine disorders are going to be hormone antagonists. All right. Again, agonists, they trigger a response. They work with the cell, and then the antagonists, they block the actions of the cells. We talked about the feedback systems, and we're going to talk about it a little bit more. A couple of primary ways that the release of hormones is regulated. It's going to be chemical and some other hormonal factors, or neural control. What would be an example of neural control to release hormones? Yeah, think about the sympathetic nervous system. The sympathetic nervous system is activated, then you have the release of what? Epinephrine and norepinephrine. So it works through negative feedback, like a thermostat. It gets hot, we bump the thermostat down to cool it off. It gets cold, we bump the thermostat up so that it'll quit working, right? The example they use here is the release of epinephrine in response to stress. You have your stress. What's activated? Your sympathetic nervous system. The adrenal medulla, where are your adrenal glands? Top of your kidneys, they're the ones that release epinephrine into the bloodstream. Then, of course, we know the effects of epinephrine, but once the stress stops, then the adrenal medulla stops releasing the hormones, and then you start getting decreases in the hormone levels in the body. Simple enough, right? With disease, the problem is just like with any other disease. There's some type of impairment with homeostasis. Normal signaling is interrupted, so the hormones can't communicate. Positive feedback is given, and then the system stops providing negative feedback to regulate function. In a sense, it's almost, well, I don't want to confuse you there. So, you know, there's a disruption, so the rest of the body can't communicate with this particular gland. The gland doesn't read the negative feedback. All it sees is things are still normal, so it doesn't release those hormones. The hypothalamus and the pituitary gland, they're closely related through the vascular system. They control peripheral endocrine organs. And then the hypothalamus, which is really more or less part of the neuro system, is part of the brain, it produces its own regulatory hormones. Now, well, let me get to that in just a minute. The hypothalamus is the primary junction where the endocrine and the nervous systems come together. Then you've got the pineal gland, which synthesizes and secretes melatonin. What is melatonin? Do y'all know? Yeah, melatonin, it helps with your sleep cycles. Then your pituitary gland, it's often called your master gland. The reason why it's called your master gland is because it pretty much controls the other glands. It has to secrete a hormone to tell the other hormones to secrete. It's located at the base of the brain, and it's about the shape of a size. The size of a grape. It's the shape of a size, guys. It's about the size of a grape. It's connected to the hypothalamus by thin tissue, and then it's divided into the anterior, which secretes 7 hormones. This is your growth, thyroid stimulating, adrenocorticotropin, melatonin stimulating, and then you've got 3 gonadotropic hormones. And then your posterior pituitary secretes 2 hormones, ADH and oxytocin. What was ADH? Antidiuretic hormone. So here is a crazy chart of the hormones and how they are secreted and released and what their target tissues are. Alright? So if we look at our anterior pituitary, if we just start up here, we've got these gonadotropic hormones. You've got FSH, follicle stimulating hormone, and luteinizing hormone. Gonadotropic acts on the gonads, the male and female gonads. Males is the testes, females are the ovaries. Then you've got your ACTH, your adrenocorticotropic hormone. It's going to act on your adrenal gland. Your TSH, thyroid stimulating hormone. Then you've got your growth hormone, which stimulates bone and soft tissue growth. Melanocyte stimulating hormone, the melanocytes in the skin. Then you've got prolactin. Prolactin, which does what? Stimulates the mammary glands to produce milk after oxytocin has started. Alright, so your posterior pituitary, you've got your oxytocin, which triggers the uterus to contract, and also after birth triggers the breast to start making milk. Then you've got your antidiuretic hormone, which works on your kidney tubules. Your thyroid gland, it secretes thyroxine. Thyroxine is the body's major metabolic hormone. Stimulates energy production in the cells. If it's the major metabolic is energy production. If you think about some of the thyroid disorders, it makes a little bit more sense whenever we get there. Thyroxine cannot be produced without proper level of iodine. Iodine. And then if you have lack of thyroxine, you really start diminishing in your physical and mental growth. Thyroid gland also secretes calcitonin, which helps maintain calcium levels in the blood. Calcium will, it stimulates bone-building cells to absorb excess calcium and then stimulates kidneys to absorb and excrete excessive calcium. Your thymus gland. Your thymus gland helps with your immune response. It's where you have your lymphocytes, you've got your killer T cells, your helper T cells, and your suppressor T cells. Your killer T cells are cytotoxic, which means that they attack antigens directly and trigger phagocytosis. Remember that term, phagocytosis? And prevents the reproduction of this antigen. Your helper T, it releases lymphokines, which deliver messages about the antigens. And then your suppressor T cells contain immune response, which can otherwise cause excessive inflammation resulting in severe tissue damage. So your suppressor T cells are what suppresses the immune response, because we know what an exaggerated immune response can do to the body, right? Your parathyroid glands, it helps regulate calcium again. It secretes PTH. What do you think PTH stands for? Parathyroid hormone. There you go. Can act as an antagonist to calcium. It's secreted when calcium blood levels are low, and it stimulates the bone-dissolving cells to break down bone and release calcium into the bloodstream, which then is eliminated through the urine. Your adrenal glands, they're pretty important. They're on the base of, or the tops of the kidneys. You've got two parts to it, the adrenal cortex and the adrenal medulla. They're paired rectangular structures. Some of the functions is to suppress inflammation, govern the body's use of nutrients, and regulate how much sodium is excreted in the urine. Now your sodium, the excretion of your sodium is going to have to do with your fluid balance. So your adrenal glands are going to have a little bit to do with your fluid balance. The hormones of the adrenal glands, you've got your cortisol. There's diseases where you have decreased cortisol levels. Your aldosterone, Your aldosterone is part of the renin-aldosterone angiotensin deal there, where it helps with water absorption and excretion, helps with your fluid balance. And then, of course, your epi, your norepi, we know what those do. Your pancreas. Pancreas has two functions. It's got its digestive function and it's got its endocrine function as well. The endocrine function is going to occur on the islets of Langerhans. Sounds like a nice place to go for a vacay, huh? Your alpha cells, they secrete glucagon. Your beta cells secrete insulin, and your delta cells secrete somatostatin. Glucagon, what does it do? When is it released? When the blood sugar is low. What does it do? So it stimulates the release of glycogen from the liver, right? All right, so starts glycolysis. So glucagon is released when the blood sugar levels are low, so insulin's released when? When the blood sugar is too high. What does insulin do? Right, it's the only way that glucose can get into the cells, right? It has to increase the cellular permeability to allow for the glucose to get into the cells. Somatostatin is excreted with increased levels of insulin and glucagon. Decreases insulin and glycogen secretion and slows absorption of nutrients. Then your gonads, it's where your sex hormones are created. In your males, your primary is testosterone, and your females, estrogen and progesterone. Endocrine system emergencies can really affect a patient. Even if it's not a diabetic patient, it can be a severe emergency. Don't take them lightly. Don't get endocrine system emergencies confused with other altered mental status emergencies or states, right? Just because somebody's acting drunk doesn't mean that they're drunk. We always need to consider endocrine emergencies when we have altered mental status, just like we do neuro. Check the home for medications. That can tell you a lot, whether they're on your diabetic medications, insulin, things like that, or whether they're on thyroid medications, or some patients have to take steroids. It can help you really identify and even help pinpoint problems that the patients may have. Now, if y'all notice, I've relied on my notes a little bit more because the endocrine system really is a complex deal, right? There's no way that we're going to become experts on the endocrine system in just one day with all of your stimulating hormones and all that. I would like for you to have an idea of the main hormones that we've talked about. Really want you to know about your glucagon and your insulin, which you should really know that real well. Want you to know about your antidiuretic hormone and your epi and your norepi and things like that. Same management assessment with your airway and breathing, with your circulation. Some disorders are going to be, you're going to have particular assessment findings that are related just to that particular disorder. Transport decision. If they're having a true endocrine emergency, they need rapid transport. Definitely want to ask about polyphagia and polyuria and polydipsia. Have they been extremely hungry? Have they peed a lot? Have they been extremely thirsty? Why would a person that has diabetes feel polyphagia? What?
Because they're not getting the sugar out of the system, then their body's thinking they need to eat more to get the sugar.
Okay. So your body does have excessive sugar in it, right? We've eaten that honey bun that I saw Jeremy eating just a minute ago and I was jealous of. We've eaten whatever that's increased our blood sugar, right? But if we're diabetic, we've got problems getting that blood sugar into the cells. So while our blood is full of sugar and nutrients, our cells are starving, right? So they're sending signals back to the brain saying, hey, we're hungry, get us something to eat. Why would a patient with diabetes feel polydipsia? Extreme thirst. Because of the polyuria, right? What does the body do with the excessive blood sugar? It dumps it out into the urine, right? There will be several atypical findings that may suggest a particular endocrine disorder. Definitely want to look at their appearance. Try to find the source of the coma. Diabetics can be easily reversed, right? And then we're also looking for hypertension or bradycardia. There's some of these that may mimic signs of shock. And then look and make sure they're breathing, of course. Reassess them, recheck their blood sugar, get them an IV, one way or another. Blood glucose levels, if it's less than 60, they'll need immediate treatment. Some of these patients may require airway assistance. If they're intubated, supine with a cervical collar. If they're not intubated, put them on side position. Sometimes these patients may have increasing intracranial pressure. We need to elevate the head 30 to 45 degrees. And that's just not just here. That's anytime you have intracranial pressure. Usually endocrine disorders are caused by a couple of things. Either hypersecretion of a gland, hypersecretion of that hormone, as in the case of hyperthyroidism, insufficient secretion of a gland, as in the case of hypothyroidism, or as in the case of diabetes, when they don't secrete insulin. If you have glucose metabolic derangements, it's caused by some function of the pancreas, whether it's not making insulin or it's not making enough insulin. Bottom line is that these do turn into emergencies. In some situations, they'll have improper fluid balance, as in the case of one of our hyperglycemia disorders. We treat them just like we would any other patient, but we're looking a little bit deeper to see what we can do to treat them. Do you know why diabetes mellitus is called diabetes mellitus? Yep, mellitus comes from the Greek word honeybee, which means sweet. So somebody along the way in coming up with a name for diabetes had to taste somebody's urine to tell if it was sweet. Why would somebody's urine be sweet? Because of the dumping of the glucose into the urine. That's some sweet sugar. If you got or sweet urine, if you've got enough glucose in your urine for it to be syrup. Yeah. Or you could just check it with a glucometer. You know? I can tell by the viscosity of my urine that I've got a sugar of 120. Oh, no, it's a little sweeter. It's 150.
And I'm out of my supplements.
We know about diabetes. It takes insulin to get glucose into the cell, right? In diabetes, if they don't have the insulin properly working, then we're going to have excessive glucose in the blood. Large number of folks in America have diabetes, whether it's type 1 or type 2. Type 2 most often is caused by lifestyle. Diabetes isn't just a disease that just affects the pancreas and the blood sugar. All right, diabetes can cause some severe damage to the body. Kidney failure. Usually, if a person has end-stage renal disease, and I'm not stereotyping, I'm just saying from my observation, it's because they had one of two problems. Either they had uncontrolled hypertension or they had uncontrolled diabetes. Most of the time when you see these patients with renal failure, I call it the triad, the Nix triad, I guess. Somebody a lot smarter probably has observed this as well. But they usually have renal failure accompanied by diabetes and hypertension. All right. Heart disease or stroke. Obviously, if you have elevated sugar in the blood, that's fats. It starts getting deposited into the bloodstream, can cause clots, increased risk of atherosclerosis and CAD. And then you've got microangiopathy that restricts blood flow. Anybody want to take a stab at what microangiopathy is? Anybody? Anybody? Yeah. Condition in which the swelling of the membrane cells restricts the flow of blood to the organ and the tissues. Causes necrosis and central nerve damage. So, if you've got clots, if you've got issues with the vasculature, you can bet your bottom dollar that you stand risk for CVA, stroke, hypertension, and that microangiopathy is associated with that. Eyes. High blood glucose levels will damage the vessels. Often you can see cataracts, you can have diabetic retinopathy. Neuropathy. Neuropathy is a bad deal. You pretty much lose feeling in your feet. That can be deadly because you can get a potentially fatal wound, and a diabetic already has impaired wound healing because they've got excessive glucose in their system. And if you've got a bad wound and you don't even know it, and then you let it fester for days and days and let that bacteria eat all that glucose in your system, then you're probably going to lose your leg if it doesn't kill you. And then as far as diabetes goes, a lot of these conditions can be prevented or delayed with lifestyle changes. I think one of the problems with America now is that we've got such an availability of drugs, of medications, that we're not willing to work to do what it takes to keep ourselves healthy when we can just give ourselves a chemical. You know, I'm not against drugs or anything, but, you know, somebody tells you, hey, you've got type 2 diabetes, all you've got to do is quit eating at McDonald's 3 meals a day and maybe get outside and walk a mile a day, and that would probably help you. Nah, I'd rather keep eating and just take my meds. Some people wear it as a badge of pride. So, we're going to talk about our type 1 and type 2 quickly. Type 1 is what? Insulin dependent. Used to be called juvenile onset because observations were made that it usually had an onset time when somebody was a juvenile. Not called that anymore. It's just called type 1 diabetes. It's not even technical term, isn't even insulin dependent diabetes. It's just type 1 diabetes. These patients are going to have daily insulin injections. Been around for a while now, very, very popular with young, otherwise healthy adults, are insulin pumps. Keeps them from having to continually inject themselves, and they can use a sliding scale, which means they can adjust their dosage of insulin based on their blood sugar. They still have to check their sugar with every meal, but they're able to adjust it. So it keeps them from having to inject themselves. So definitely an assessment finding that we need to probably turn off if we've got a hypoglycemic patient, right? Hypoglycemic diabetic patient, they've got an insulin pump. We need to figure out how to turn it off. If we don't, what's going to happen? Everything that we do for them is just going to get, they've got an excessive amount of insulin, so we can give them D50 and it's just going to get metabolized very quickly. And so with type 1, the islets of Langerhans in the pancreas does not produce insulin. Big push for compliance. Big push for compliance. Great place in Opelika, the Diabetes Treatment Center. They do a lot of education, and they do a lot of training with diabetics, and they help them manage their medications, and they help them manage their insulin and things like that. And they figure that if they can use the resources to educate them, then it'll be resources well spent, and it won't put a strain on the healthcare system by them not managing their diabetes. Do not think that because somebody has a diabetic emergency that it means that they are poorly managing their diabetes. It's bound to happen at some point in a diabetic's life, even if they're managing it very well. It's bound to happen that they're going to get sick, they're going to exert themselves, they're going to accidentally give themselves too much insulin or something like that, and they're going to have some type of emergency. All right. So just don't think that just because you go to a diabetic patient one time with low blood sugar that they're not compliant. Now you go to that patient week after week, every other day. Yeah, they're not doing something right, and they should probably get some help. Also, a lot of times you may be the first healthcare provider that some of these patients have seen in a long time. Do a good assessment. Check for sores, especially on their feet, infections, and things like that, because that's something that may need to be brought to the attention at the ER. That might be the reason why they're having a hyperglycemic emergency, all right, because they've got an infection. So type 1 diabetes management is going to be, as far as with the patient, is going to be insulin. They're going to know what type of insulin they're on. They're going to know when to take it. The doctor's going to educate them, or the diabetes place will educate them. No newly diagnosed patient should ever be sent home with a prescription saying, okay, you've got diabetes, you need to give yourself insulin. All right? It's a requirement that diabetic patients have some type of education before they are sent home. Now, we're going to get into our hospital management here in just a few minutes. Type 2. Type 2 diabetes is usually diagnosed later in life, usually a result of some type of other metabolic syndrome or some type of lifestyle, sedentary lifestyle. Many of these patients are insulin resistant. So this means that their body may produce insulin, but it may not work. Or in some cases, their body still produces a little bit of insulin, but it's not enough. A lot of these patients may be walking around with type 2 diabetes and never know. I saw several during my career in the hospital. I saw several patients that came in with, they were in HNKC with a blood sugar of 1,000, just said, I've not been feeling good for about 3 months. I don't know why, I've been tired. And they get diagnosed with type 2 diabetes because now they've got a blood sugar of 1,000. So again, some of these patients may not be diagnosed, and you may be the first healthcare provider that they've seen in a long time. Strongly encourage a good assessment and getting them to the hospital. All right? Some of the symptoms, some of the typical symptoms, frequent urination, thirst, also have blurred vision. All right? Management. Diet and lifestyle change, weight loss and exercise, food intake, small meals during the day, then they will probably require medication and in some cases insulin. A lot of type 2 diabetics can manage their type 2 diabetes with diet and exercise. I'm not going to believe a 300-pound person that has been sitting in their chair watching TV all day long that they manage their type 2 diabetes with diet and exercise. All right? They have type 2 diabetes that is not being managed is what it is. Then you've got gestational diabetes. Usually it's from glucose intolerance during pregnancy, usually in later terms of pregnancy, so it doesn't really affect the development of the child. One of the effects, though, is going to be a large baby. These patients usually will require a cesarean section. They're going to have just stabilized blood glucose levels, probably more frequent visits to the doctor. And then, of course, just because you got a baby in your belly doesn't mean that you can't exercise and eat right. Hypoglycemia. Usually is going to, I'm not going to say exclusively, but primarily a hypoglycemic event that's led to unresponsiveness, or what your typical hypoglycemia event is usually going to be a type 1 diabetic that's either taking their insulin and not eating enough, or taking too much insulin. All right? Or both. Hypoglycemic patients are often confused with what? Drunks. Incoordination, slurred speech, irritability, headache. Any of y'all run a call on a diabetic patient that was just the biggest meanie head that you've ever met? I have. They get fighting. Scare you. They're saying hypoglycemia is when the blood glucose level drops to 45 or less. Normal blood glucose ranges are 60 to 120. Definitely, any patient that's got bizarre behavior, neuroscience, coma, even if you can't get a good history on them, go on and check their sugar. Remember your reversible causes of everything. If we get there and they're still awake, we're going to give them what? Oral glucose. If they're not awake and they got a sugar below 45, we're going to give them what? D50. How much? 25 grams. Your book says 12.5 to 25 grams. In most cases, you're just going to give them a whole amp. Some places may use a little formula. We did in the hospital. We didn't on the ambulance, but in the hospital we used a little formula to figure out how much to give. Nonetheless, the idea behind giving a full amp of D50 in the field is the fact that you've got a transport time, right? So you probably won't be making them a sandwich in the back of the truck on the way to the hospital. So we need to give them enough, because that stuff's going to get metabolized pretty quickly, right? If they've got excessive amounts of insulin, that just straight glucose is coming in, it's going into the cells. And then, of course, if we don't get a line, then our next step is what? Glucagon, IM. How much? 1 milligram. Now, with our hypoglycemic patients, I know this is a review, but I think it's very important that we remember, whenever we get somebody's blood glucose up, what do they need to do immediately? Eat. Do they need to drink orange juice and all that? Well, they may, but what do they really need? Protein. Give them a can of tuna fish or a turkey sandwich or something like that. All right? They need protein. Hyperglycemia. Hyperglycemia. Most people with diabetes probably lives in hyperglycemic states more than they do hypoglycemic states. Occurs when the blood glucose exceeds 120. Usually don't see a whole lot of issues until it gets on up. All right, especially a long-term diabetic who's probably used to living with a sugar of 180. You know, untreated hyperglycemia leads to DKA. What happens in DKA? Somebody explain it to me and we'll move on.
The body has to metabolize its own cells to make energy, which produces ketones and stuff, which then increases the acidity of the actual body. So
Right. So the body has all this glucose, but the cells aren't able to get it. The cells need oxygen and glucose to metabolize. So they start eating the fatty acids in the cell, which the byproduct of that is ketones. The ketones increases the acidosis up in the body, and then you have a pretty bad deal. Now, DKA, depending on where you look, some folks say DKA is in the range of 600 to 400, 300, and then HHNC is a little bit higher. I've seen HHNC usually does get higher than DKA, all right, as far as glucose levels are concerned. But I've seen people with greater than 800 and not be in a coma, all right? So, of course, your glucometer is not going to read that high, but if they've got the classic symptoms, signs and symptoms of DKA or HHNC, then we're going to treat them as such. Signs and symptoms of DKA. The acetone odor on the breath, abdominal pain. They're going to have to go to the hospital to get insulin therapy. All right? We don't give insulin in the field. It's too hard to manage in the field. We can cause rapid drops very quickly. These patients with a blood glucose of 600, they need to come down from 600 to 120, not in the course of an hour, but in the course of probably about 12 hours. All right? The body can't withstand excessive drops. With DKA, we want to monitor the cardiac rhythm. We want to monitor the cardiac rhythm because insulin and potassium kind of go hand in hand, all right? And there may be excessive amounts of potassium in the body, and so we're looking for our sharp peak T waves. As the K levels rise, the QRS complex will widen, and then you'll start seeing the sine wave and the T wave. And then these patients may need calcium chloride or calcium gluconate, all right? So think of these patients with any type of electrolyte imbalance, and you start seeing a widening T wave and a sine wave, and then bradycardia. They may need calcium chloride or calcium gluconate, and I'm not even sure if calcium gluconate is still on the truck or not.
That's what. Are we?
What do you think calcium is?
Mm-hmm.
We're carrying chloride now.
Yeah.
Calcium
What are the
chloride.
others?
I don't work the drug box there.
I want to
6
say,
miles away.
I used to carry
Yeah, it used to be calcium gluconate, and then they realized they had tons and tons and tons and tons and tons of bottles of calcium gluconate going out of date because it wasn't hardly ever used. Hyperosmolar non-ketotic coma, also HHNC, HHNK. It is hyperglycemia without the production of ketones, primarily with type 2 diabetes. The problem with this is that they become hyperosmolar. What does that mean? It means that the urine and the glucose is dumping into the urine. All right, it's increasing the osmolarity of the plasma and the cells, and it's pulling water. The water's following the urine. Urine gets peed out. What happens? You're in trouble. You become dehydrated. All right. So patients aren't going to experience the typical signs you see with DKA, the Kussmaul's respirations, things like that. They may be lethargic. They're going to feel like crap. They may have seizures. A lot of them have a history of diabetes. A lot of them just may be what diagnoses them with diabetes. Again, they've got a very high glucose level. It's got to be brought down by an insulin drip. It's got to be brought down slowly. So our treatment for any hyperglycemic emergency, and especially DKA and HNK, is is going to be symptomatic treatment, airway treatment, and fluids. Some cases, these patients may receive 1 to 2 liters in the first hour. They say administer D50 if the glucose level is less than 60 to 80. I don't know where that came from. All right? I've never seen a hyperglycemic patient with a hypoglycemic. Other than what it just occurred to me, what they're saying is not even related to y'all. If they get that blood sugar down, we had a protocol that we would follow. We'd get the blood sugar down. Once it got to about 250, we would put them on fluids. We'd put them on D5 to start introducing some sugar back in because the sugar was going to continue to drop really quickly. I don't see y'all transporting somebody with an insulin drip that's going to affect you in that way. Pancreatitis. Inflammation of the pancreas. Pancreas has digestive and endocrine functions. Usually, pancreatitis is usually from a clogged duct that's going to cause the inflammation, cause the backup of the pancreatic fluids, the enzymes. Flanker epigastric pain. It hurts right in this area. Nausea, vomiting, abdominal distension. Management, supportive. Treat for pain. Adrenal insufficiency. The adrenal gland, it produces cortisol and aldosterone. When the adrenal gland starts having insufficient production, you start having issues. Addison's disease. Y'all have heard this term, Addison's disease, primary adrenal insufficiency. Leads to deficiency of steroid hormones. All right, corticosteroid hormones. Occurs when 90% of the adrenal cortex has been destroyed. Some of these signs, this is the same person. They've got increased pigmentation in the right hand, normal pigmentation in the left hand. They often will have salt cravings. And it's going to be with all the electrolyte imbalances. With Addison's disease, the body's going to improperly regulate sodium, potassium, and water in the body fluids. Blood volume and pressure starts to fall, so we're looking for decreased blood pressure. The salt cravings is because you start losing sodium, and as you lose sodium, your potassium increases. So if they start having increased potassium, we definitely want to be looking at EKGs and stuff like that. Now, are we going to identify this in the field? They probably know that they've got some type of endocrine disorder, right? They're going to need aggressive fluid replacement because they've lost a lot of fluids, and then they'll have to get hydrocortisone in acute management, but it'll be at the hospital. Secondary adrenal insufficiency. Characterized by a lack of ACTH secretion from the pituitary gland. ACTH, adrenocorticotropic hormone, which stimulates the adrenal cortex to manufacture and secrete cortisol. These patients have been on some type of steroid treatment, then they just stop taking it, then they start having some bad issues. An Addisonian crisis is when this insufficiency appears suddenly. And it is a medical emergency, but we may not necessarily identify it as that because we're still going to be doing symptomatic treatment. Cushing Syndrome. What's characteristic assessment findings of a patient with Cushing Syndrome? Cushing Syndrome, they're going to have the moon-shaped face, the rounded face. Oftentimes they'll have a hump back. All right? It affects the bones and it's because of excess cortisol production. Again, really the only way you're going to know that they have Cushing Syndrome is probably because you got called for some other reason and you noticed the characteristic round face and the humpback.
It says in my book, excess cortisol causes high blood glucose levels. In Kimberly's book, it says low blood glucose levels.
Seriously?
Yeah.
Literally the same. It's
I mean,
the fourth bullet.
every
It's
time.
mine as well.
What page?
1230.
That's a bad thing.
Under what?
It's 1233. Fourth bullet.
Yeah, mine says low blood glucose levels.
Mine says high.
Mine says high.
I'll say every other person in the class got.
JV learning is awesome.
I was confused when I read this too. I didn't know if it made it go up or down. Was good.
Okay. I'll bring it to their attention. Anyways, mainly supportive. We're going to check blood glucose levels in these patients. Give D50. Adrenal gland tumor. This word right here causes excessive release of hormones. CAH, congenital adrenal hyperplasia. All these signs that you see here. Hypo and hyperthyroidism. The anterior pituitary gland, it secretes TSH. TSH is thyroid stimulating hormone. What is that going to stimulate? The thyroid, right? It's going to stimulate the thyroid to release thyroid hormones. Y'all could have said that and been right. Right?
But is that the most right answer?
Maybe. These patients, though, they can be in some pretty serious danger if they start having, especially hyperthyroidism issues. All right. Graves' disease, it's the most common cause of hyperthyroidism. Graves' disease produces a visible mass in the neck. What is that also called? A goiter. A goiter. This is where excessive amounts of thyroxine is secreted. So, what do you think they're going to have to do? Limit the amount of thyroxine that's secreted, right? Hashimoto Disease. Another cause of hyperthyroidism. Affects your TSH receptors. Myxedema Coma. This is what's pretty serious. This is, and it affects people of all ages. If they've got thyroid issues, it can really, it can kill somebody dead. Symptoms of this: fatigue, feeling cold, dry skin. As the hormone levels continue to drop, they go into Myxedema Coma. And then we would treat them as an unresponsive patient, and they would do tests. They would test TSH levels and things like that. Thyrotoxicosis, also known as Thyroid Storm when it gets severe. Excessive amounts of thyroid hormone. It's rare but life-threatening. These are going to be those patients that have all this like hyperactivity going on, and they're unresponsive, but their heart's going crazy, their fever, all this stuff, and you just can't really put your finger on it, and so you're still just going to have to manage symptoms. All right? Hyperparathyroidism, increased parathyroid hormone. They'll have to have their parathyroid gland removed, and we're going to treat their ABCs. Panhypopituitarism. I'm just finishing up with this because we're almost done, and we'll be caught up. The pituitary hormones are going to be inadequately produced. Diabetes insipidus. This is where we have a lack of ADH. What does ADH do? Yeah. It keeps you from peeing, right? So if you have a lack of ADH, what's going to happen? You're just going to keep peeing, keep peeing, keep peeing, keep peeing. And you've got a couple of hereditary diseases.